Sleep apnea, obesity, and anesthesia. Potentially deadly combination. Okay? Already, sleep apnea is serious.
I know. Didn't help right there.
All right, here, this is better. Nothing to worry about. Everything's fine. I don't know why you're worried. Nothing to this. Everything's fine. All those things we wrote, the complications, they never happen. Nothing to happen. So the serious issues of going to sleep with an obese person and sleep apnea are that the anesthetic drugs, which are necessary to help protect you from pain and awareness, also depress respirations. And if you're already obese and you're on sleep and you have sleep apnea, that's a problem. On the other hand, you saw people in clinic who had sleep apnea. You probably talked to dozens or hundreds of my patients that have sleep apnea, and we do a superb job of managing that very difficult problem. And probably, in my opinion, there may not be anybody in the country that does any better. Okay? Number one, we use specialized techniques that don't depress respirations. The anesthesia that we use, in contrast to some kinds of anesthesia, doesn't decrease breathing and respirations, but stimulates it. So if you remember in your permit, there's a section in there on an old drug that we use called ketamine. Now, ketamine has some downsides, but one of its real positives is it supports blood pressure and it stimulates respirations. And it takes away pain and it gives anesthesia. Narcotics, which is very good for pain and sedation, has the disadvantage of causing nausea, like codeine, but also depresses your breathing. So we want you to have pain relief, but we want to avoid as much narcotics as we can to protect you from the problems of the sleep apnea, obesity, and the anesthesia. And the combination that we use with dexmedetomidine, a new drug called Precedex, ketamine, and the drips that we use during surgery, we have shown are excellent in protecting your oxygen saturations, keeping your breathing, and protecting you from problems in the postoperative period. No, it's bad. But it shows, but that's the way you look. That's what, you remember the little round lady who was sitting in front of you from Canada? Yes. Yeah. 93, it should be 100%.
Right.
And yours is 93, that's not good. But that's why you're here. Okay? In other words, what we hope and pray and expect is just like Winnie, who we saw in clinic the other day from Canada, we're going to make that better. And we're prepared for dealing with that 93 or 88 or whatever you have by the techniques that we just described.
What if he requires an extra night because of the bed? And we're in a hotel, and of course they don't have what hospitals have, and I can't get him out of bed. You know.
We have 98 to 99% of our patients go home the next morning, so we're looking forward to that for tomorrow for the hotel. But if you have some illness, or like Winnie had, she had poor oxygenation, we kept her a couple of extra days. So we're able to do that. We have some people who say, I'd like to stay because it's convenient, or I want to save on a hospital. We say, save on a hospital bill, save on the hotel bill. I said, no, you're not going to save any money on it. But yeah, you're able to stay as long as we think it's good for you.
Okay, his mobility, that's my biggest concern.
Right.
And it's just me and him.
No, you can lift him around.
Yeah.
Blood pressure medication.
Mm-hmm.
I'm on Senapril right now.
Right.
I took it last night. But,
Good. Don't take